Welcome back to the Deep Dive Ortho, the space where we stop skimming and start synthesizing. Today, we're taking a deep dive into the upper limb's mechanical Achilles heel, the forearm. And we're going far beyond basic fracture care. We'll be exploring the whole spectrum, from the immediate limb-threatening emergency of compartment syndrome, right through to the really complex salvage procedures needed to restore that vital rotational function. When you think about it, the forearm is just an incredible piece of engineering. It's not just two bones.
Not at all.
That ability to get 180 degrees of rotation, the pronation and supination, is just fundamental to daily life. It's how you turn a key, drink a coffee.
Everything we do with our hands depends on it.
Exactly.
Yeah.
So when that kinetic chain is broken, it's not just a stiff joint. It's a genuine functional disaster for the patient.
That functional consequence is precisely where our focus has to be as surgeons. We have to treat the forearm with absolute precision. It's best to think of it not as two bones, but as a stable ring structure.
Okay, ring structure.
Yes. You've got the radius and the ulna, and they're linked by three crucial articulations. The proximal radial narrow joint at the elbow,
The PRU?
the DRUJ, the distal radial narrow joint at the wrist, and critically, the interosseous membrane, the IOM, running between them. If you compromise the position or the integrity of any one part of that structure, the whole system for load transfer and rotation is immediately destabilized.
So it's about respecting that dynamic stability.
That's the whole game.
Right. Well, if we're talking about high stakes, we have to start with the most urgent complication in forearm trauma, the one that demands immediate action: acute compartment syndrome. Acute compartment syndrome, or ACS, is a diagnosis that, frankly, is terrifying. We understand the mechanism, right? The pressure just skyrockets inside a closed fascial compartment.
The closed osteofascial compartment, yeah.
And that leads to impaired circulation, ischemia, and then, if you don't act, necrosis. It is, without a doubt, a surgical emergency.
And the window for intervention is brutally unforgiving. And while, many of us instinctively think of the anterior compartment of the leg with ACS,
That's the classic one.
it is. But we must be just as vigilant, if not more so, with the forearm, the hand, the thigh, even the buttock. Anywhere you have muscle wrapped in that inelastic fascia is vulnerable. In the upper limb, the causes can be anything from crush injuries, reperfusion injuries after a vascular repair,
Right.
to simple local trauma. But overwhelmingly, the most common cause is a fracture. Distal radius fractures in adults, and of course supracondylar humerus fractures in children. The hematoma and edema just build up so quickly in those tight spaces.
Diagnosis is where it gets really critical, isn't it? Because a mistake there can cost a limb. We're taught it's a clinical diagnosis, but the signs can be so subtle, especially in a polytrauma patient who might be sedated or have a nerve block.
They can, which is why you have to rely on the fundamentals. The classic first symptom is always pain out of proportion to the injury, a level of pain that just doesn't add up.
But you can't always rely on a pain score.
You can't. So for the clinician at the bedside, the single most sensitive clinical finding is pain on passive stretch of the muscles in that compartment. For the forearm, that means pain when you passively extend the fingers and wrist.
That's the one to look for.
That is the one. If you're waiting for objective signs like paresthesia, numbness, that already tells you the nerve is ischemic. And if you wait for paralysis,
That's far too late.
that is a very late sign. And sadly, full functional recovery from that point is rare. You have to act long before then. You'll also feel a palpable swelling, a tense, woody feel to the forearm.
And what about using pressure monitors? That threshold of 30 millimeters of mercury is often quoted. How should we integrate that data?
It's a helpful tool, certainly. A reading over 30 millimilli Hg can confirm your suspicion. But here's the danger. Relying only on the monitor.
A single normal reading doesn't get you off the hook.
Never. A single normal reading must never, ever rule out ACS if your clinical signs, especially that pain on passive stretch, are telling you otherwise. And you have to consider the patient cohort. We know fractures are the most common cause. But when there isn't an obvious fracture, what's the next most common trigger?
I suppose something that causes bleeding.
Exactly. The evidence is clear that it's a patient on therapeutic anticoagulation or with a bleeding disorder. You take a 48-year-old on therapeutic Lovenox with a moderate crush injury. That patient's threshold for a dangerous hematoma is dramatically lower. You have to look at the whole patient, not just the limb or the monitor.
That really changes the focus, doesn't it? It's about managing the patient, not just the injury. So once you have that high index of suspicion, what are the immediate steps?
The initial non-surgical steps are limited, but they're mandatory. First, split or remove everything. Any tight cast, any dressing, any circumferential wrap comes off immediately.
And what about limb position?
This is a critical point that's often misunderstood. You maintain the limb at the level of the heart.
Not elevated.
Absolutely not elevated. The natural instinct is to elevate to reduce swelling, but that reduces arterial inflow. It lowers the pressure gradient you need to perfuse the compartment against that rising internal pressure.
So keeping it level with the heart maximizes the perfusion pressure?
It buys you precious time. You also need to make sure the patient is normotensive. If their systemic blood pressure drops, perfusion to the compartment drops with it, and the ischemia gets worse, faster.
And if those steps don't work and the decision is made to go to theater?
Then there is no ambiguity. The surgical principle is complete decompression via an extensive fasciotomy. There is no role for a limited or, a small incision fasciotomy in the forearm. It's inadequate.
And timing is everything.
The prognosis is dictated entirely by two things: the intensity of the pressure and its duration. And this brings us to that brutal time constraint. A fasciotomy is actually contraindicated in delayed cases, usually after about 24 hours.
Why is that?
Because if you revascularize tissue that is already necrosed, you release a flood of toxic metabolites into the system. Myoglobin, potassium. It dramatically increases the risk of septicemia, renal failure, and even death.
So there's a point of no return?
There is, which leads to the fundamental rule of ACS management. When in doubt, cut. When in doubt, perform the fasciotomy. A scar is a minimal consequence compared to a lifelong debilitating Volkmann's ischemic contracture. You have to err on the side of decompression.
A very clear and compelling summary. So let's move on from that acute vascular crisis to the acute mechanical one, because stabilizing the limb is only the first step. The next challenge is preserving that intricate mechanical stability needed for rotation, and that seems to hinge on two key features: the interosseous membrane and the geometry of the radial bow. So the mechanical complexity of the forearm is, well, it's just remarkable, isn't it? The way the radius rotates around the ulna. Let's talk about the interosseous membrane, the IOM. I think that its role is often really understated.
It really is. To think of it as just a passive sheet of tissue is to completely misunderstand its sophistication. It's a complex structure, really a composite of 5 distinct ligaments.
5 ligaments?
Yes, but the undisputed star of the show is the central band, the CB. Its structure is defined by that oblique orientation of its fibers. They run from the radius, proximally, down to the ulna, distally.
At a specific angle, right?
At about 21 degrees. And that specific angle is the design genius. It's lax enough to allow full rotation, but it's taut enough to be the primary load transfer mechanism between the two bones.
So in practical terms, how much load is it actually taking on when, say, you're pushing open a heavy door?
Under that sort of axial compression, the IOM acts as the main shock absorber. It transfers force from the radius, which takes most of the load from the wrist, across to the ulna. Roughly 60% of the axial load goes up to the radiocapitellar joint, and about 40% goes to the ulnohumeral joint. The IOM is what allows that distribution.
Okay, that covers load transfer. But you also mentioned its role changes with rotation, which is where it gets really interesting.
This is where the dynamic stability comes in. Now, while the central band is under the most strain in neutral rotation, its biggest contribution to load transfer is actually in supination.
In supination?
Yes. Biomechanical studies have shown it transfers significantly more load from the radius to the ulna in supination, up to 17% of the total applied load.
And what is it in pronation?
It's much lower, only about 6%, similar to neutral. So this gives us a crucial clinical insight. The IOM is under maximum stress and providing maximum stability in supination. That's why in these really unstable injuries like an Essex Lopresti, we are so worried about losing stability in supination. The IOM is what's resisting that proximal migration of the radius.
Understanding that dynamic role is essential, but stability isn't just about ligaments, it's also about the shape of the bones themselves. We spend so much time in theater getting the length right, but the contour, that physiological radial bow, seems just as critical.
It's not negotiable. The radius isn't a straight rod. It has a very specific curve, a bow, that arcs away from the ulna.
And that space is what allows the rotation.
Precisely. If you lose that bow during fixation, even if your length is perfect and your joints are reduced, you have created a mechanical block. Rotation will be lost. And for surgeons planning their fixation, the anatomy is very consistent. The point of maximal radial bow is at about 44% of the way down the radial shaft, just distal to the pronator torus insertion.
So missing that specific anatomical target guarantees a poor outcome.
It guarantees functional compromise.
Let's quantify that. For the clinicians listening, what is the actual functional penalty for getting that bow wrong?
The data is quite dramatic and comes from cadaver studies. They simulated a malunion by reducing the curve of the radius, and the results were stark. Just reducing the radial bow with no rotational deformity at all caused a statistically significant 20% loss of pronation.
20%?
Yes, from an average of 77 degrees down to 62, and a 19% loss of supination down from 111 degrees to 91.
That is a huge penalty just for geometry.
It is, and it gets worse. When you combine that loss of bow with the rotational malunion, the effects multiply. For example, a 40-degree malunion in supination with a reduced bow led to a 59% loss of pronation.
Wow.
The message for every surgeon is crystal clear. Getting length and putting the pieces together is the basic requirement. But restoring the anatomical contour, restoring that radial bow, is what defines a successful functional outcome.
A superb clinical takeaway. Let's shift our focus now to the classic injury patterns that really exploit these biomechanical weak points. So moving from isolated fractures, we get into the really complex fracture dislocations, the injuries that shatter that stable ring structure. When both bones are broken, we know it's a high-energy injury, and ORIF is the standard. But what's the long-term outlook for these patients?
That's a great question because we have to be realistic with them. Studies that have followed these patients for over 20 years show a consistent pattern. There is persistent objective strength loss. They typically only get back to between 68 and 75% of their normal grip and rotation strength, even with a perfect X-ray.
And what about their own perception of their disability?
This is the crucial insight that surgeons often miss. Patient-reported disability scores, like the DAS score, don't correlate that well with their range of motion.
Really?
No, they correlate much better with subjective factors, chronic pain levels, and a psychological factor called pain catastrophizing.
That's fascinating. It suggests that our job doesn't end when the bone is healed.
Absolutely not. If a patient is intensely focused on and magnifies the threat of pain, their functional disability will be higher, regardless of whether they have 70 or 80 degrees of rotation. It means that for these high-energy trauma patients, a multidisciplinary approach to rehab with robust pain management and psychological support has to be the standard of care. Fixing the bone is only half the battle.
A really vital point. Now let's break down those classic named fracture dislocation patterns.
We have to know these cold. First, the Monteggia fracture. That's a fracture of the proximal ulna with a dislocation of the radial head. In adults, the most common is a type 2, where the ulnar fracture and the radial head both displace posteriorly. That's about 80% of cases. And you have to be on the lookout for associated injuries. High rates of radial head fractures and, importantly, injury to the posterior interosseous nerve.
And the other classic pattern
Is the Galeazzi fracture. It's essentially the opposite. A fracture of the radial shaft with the disruption of the distal radial ulnar joint, the DRUJ. These are less common, about 7% of adult forearm fractures. The key here is not to miss the DRUJ injury. You're looking for widening of the joint on the X-ray, maybe an ulnar styloid fracture, or radial shortening of more than 5 millimeters. If you just fix the radius and miss the unstable DRUJ, the patient is left with chronic wrist pain and instability.
both challenging. But the one that really represents a total failure of that longitudinal stability is the Essex-Lopresti injury. This is the one that really demands a high index of suspicion.
It is a devastating triad, and it's almost synonymous with a missed diagnosis. You have a comminuted radial head fracture, a tear of the interosseous membrane's central band, and a disruption of the DRUJ.
And it gets missed because the focus is on the elbow.
Exactly. The elbow is grossly swollen and fractured, so the wrist pain is often dismissed. The longitudinal instability just isn't recognized acutely.
So if a patient comes in with a nasty radial head fracture, what are the red flags that should make us check the entire limb?
High suspicion is rule number one. Any highly displaced radial head fracture has to be treated as a potential Essex-Lopresti until proven otherwise. You look for wrist pain. You actively examine for an unstable DRUJ, which means stressing it, and you scrutinize the X-ray for any sign of proximal radial migration, which shows up as an ulnar plus deformity.
Are there any quantitative clues?
There are. One study showed that if the proximal radius is displaced laterally by more than 5.5 millimeters, with the elbow in supination and extension, that's highly associated with an IOM tear. Also, if you can distract the radius distally by more than 2 millimeters under the image intensifier, you have to suspect a central band tear. These are the small details that save a patient's function.
Let's talk about the absolute worst case scenario for treatment. If the surgeon simply excises the radial head acutely, why is that single decision so biomechanically devastating?
It's catastrophic. The radial head is the primary longitudinal stabilizer of the forearm. In an Essex Lopresti, the IOM, which is the secondary restraint, is already gone. So if you then excise the radial head, you have removed the only remaining block to proximal migration.
So the whole radius just shifts upwards.
The entire radius migrates proximally, the forearm shortens, and the load distribution is completely destroyed. A staggering 90% of the axial load now goes through the already damaged IOM and onto the ulnar side of the wrist. It guarantees rapid erosion of the capitellum, a chronic, painful DRUJ dislocation, and debilitating ulnar impaction syndrome. Acute radial head excision in this setting is a recipe for disaster.
That sets the stage perfectly for our next segment, the surgical imperatives for fixing these complex injuries. Okay, so that establishes the danger. Let's turn to the operative principles. For a standard both-bone forearm fracture, the goal of ORFF is an absolutely anatomical reduction. You need to restore length, apposition, and that critical rotational alignment.
And the radial bow.
And the radial bow. So what are the technical must-dos when it comes to plating?
The radius is generally fixed first. It sets the length and contour, and the ulna can then be aligned to it. The standard is a 3.5 millimeter plate, either a DCP or an LCP. And the key is secure fixation. You must get 6 cortices, which is 3 bicortical screws, both proximal and distal to the fracture.
And what's the thinking behind using locking versus non-locking plates?
Depends on the fracture. For a simple transverse fracture, you might use a standard compression plate to get absolute stability in primary bone healing. But for a comminuted fracture, you have to use the plate as a bridge or buttress to hold the length. And that's where locking plates, LCPs, are so valuable, especially in osteoporotic bone. They create a fixed angle construct. It's essentially an internal fixator. It maintains alignment even if the screw purchased in the bone isn't perfect, and that really reduces the risk of failure.
Right. Now, for the really difficult decision, the radial head dilemma in these complex injuries. If we know excision is a disaster, how do we choose between fixing it and replacing it?
The decision is all about preserving the lateral column. We cannot afford for it to fail. So fixation is what we attempt in younger, high-demand patients, but only if the fracture pattern allows for a stable construct.
So not too comminuted.
Exactly. You might use small headless locking screws or a tripod technique for 3 large fragments. But it's technically very demanding. The threshold for replacement should be low if there are more than 3 articular fragments, or if there's significant comminution, especially in an Essex Lopresti. You need a robust lateral column immediately.
And what's the key pitfall with a replacement?
Overstuffing the joint. If the prosthesis is too long, it tightens the whole elbow, restricts movement, and accelerates wear on the capitellum. You have to measure precisely, often referencing the other arm.
So let's say you've confirmed an Essex Lopresti on the table. How do you achieve longitudinal stability right there and then?
The acute repair is critical. The outcomes are so much better with the first operation.
Yeah.
So first, you deal with the radial head. Either fix it perfectly or replace it, getting the length just right. Second, you have to address the IOM and the DRUJ at the same time. The central band is torn, so we have to artificially suspend the radius to offload it and let it heal.
And how do you do that?
We use modern synthetic devices, things like the Arthrex tightrope or a fiber TAFE loop. It's a minimally invasive way to create a flexible link between the radius and ulna, recreating the function of the central band.
It's like an internal splint.
It's an internal length-restoring device, exactly. At the same time, you have to stabilize the DRUJ, so you repair the TFCC if you can, and then you temporarily cross-pin the DRUJ with K-wires. 2 wires just proximal to the joint, going through all 4 cortices, holding it reduced for about 8 weeks. That prevents any rotation and protects the healing IOM.
That acute protocol seems very clear, but the real surgical nightmare is the chronic Essex Lopresti patient, the one who comes to you months later with a fixed deformity.
That's the major salvage case. The IOM has lost any potential to heal, so you need a comprehensive, multi-part reconstruction. The consensus is that you need 2 things, an IOM reconstruction and a joint leveling procedure, which is usually an ulnar shortening osteotomy. That levels the wrist joint and takes the pressure off.
And what's your preferred technique for that IOM reconstruction?
I favor a hybrid reconstruction. So we do the ulnar shortening first. We address the elbow joint, maybe removing a failed prosthesis. We cross-pin the DRUJ in supination. Then we do a dual-tunnel reconstruction of the IOM. The first tunnel is for a synthetic reconstruction. We pass a strong, fiber tape loop between the bones, recreating that 21-degree angle of the central band. That provides immediate, robust mechanical stability. It's the bodyguard.
And the second tunnel.
The second parallel tunnel is for the biologic reconstruction. We pass an autograft, like palmaris longus or an allograft, through that tunnel. This biologic graft is placed in a stress-shielded environment, protected by the synthetic tape, which allows it to heal and mature over many months into a permanent living ligament.
That is an incredibly detailed salvage operation. What's the realistic outcome, and what's the final procedure you're trying to avoid with all this effort?
The patients are significantly improved. Less pain, better stability. But we have to be clear with them, they will not be normal. The goal, the critical success, is to avoid the ultimate salvage, the one-bone form.
Which is fusing the radius and ulna together.
Exactly. It creates stability, but at the cost of all pronation and supination.
Yeah.
It is a functionally devastating outcome that we try to prevent at all costs.
Let's transition to our final segment, looking at a late complication that also destroys rotation, radial ulnar synostosis. So radial ulnar synostosis, or RUS, this is when a bony bridge forms between the radius and ulna, completely locking out rotation. It's rare, under 10% after plating, but the functional effect is just devastating.
It is. The hand becomes fixed in one plane. It's a massive disability. This is a process of heterotopic ossification triggered by the initial trauma and the surgery itself. And the key for surgeons is knowing who is at high risk of it recurring after you resect it.
And who is that?
The biggest risk factor is a concurrent traumatic brain injury, a TBI. For some reason, those patients have a much higher drive to form this ectopic bone.
If it does form, resection is the only option. But the timing is so important. Too early, it comes back. Too late, and you're dealing with terrible stiffness. What's the sweet spot?
The timing is crucial. If you operate while the biological process is still hot, the recurrence risk is unacceptably high. If you wait too long, the soft tissues contract and you'll never get the motion back. So the general consensus is to operate between 6 months and 2 years post-injury, ideally in that 6 to 12-month window. You wait until the radiographs show that the bony bridge is mature and it's stopped growing.
And when you resect that bone, what do you do to stop it from just growing back? I know interposition materials are used.
Yes, resection alone has a terrible recurrence rate. So you have to put something in that gap. The controversy is what to put in.
What are the options?
Well, you can use autografts, like a vascularized muscle flap from the aconius or some fascia lata. They integrate well. Or you can use allografts. Historically, people even use synthetic materials like silicone sheets, but they have their own problems. The evidence suggests that using something is better than nothing, but the specific choice often comes down to surgeon preference.
And beyond that physical barrier, are there any other adjuncts, drugs or radiation to suppress the recurrence?
Yes, especially in those high-risk TBI patients. We use non-steroidal anti-inflammatories, like indomethacin, for about 6 weeks post-operatively. It helps inhibit that inflammatory cascade that drives bone formation. The other option is low-dose radiation therapy, delivered right after the surgery, to target those proliferating cells.
And I imagine the post-op rehab is critical.
It's non-negotiable. The moment that rotation is restored on the operating table, it must be maintained with immediate, intensive, and sustained physical therapy. Without that early movement, all the surgical gains will be lost to soft tissue contracture.
This has been a truly comprehensive journey through the forearm. We've gone from that acute crisis of ACS, stressing vigilance in anticoagulated patients and the need for prompt, full fasciotomy, to the very bedrock of mechanics, respecting the IOM's role in supination and the devastating consequences of misaligning the radial bow. And finally, we've detailed that whole spectrum of instability, from Monteggia and Galeazzi patterns to the Essex-Presti triad, really underscoring why acute radial head excision is such a failure and why the chronic cases demand that multi-staged hybrid reconstruction.
If we try and tie all this together, I think the functional outcome of any forearm injury really hinges on one thing: respecting the subtle, complex anatomy of the rotational axis. The challenge isn't just putting a plate on a fracture.
No.
It's about restoring the dynamic stability of 3 joints all at once: the PRUJ, the DRUJ, and the IOM. It forces us to ask, with every single case, are we just treating a line on an X-ray, or are we restoring the entire functional segment?
A truly invaluable perspective. If you found this deep dive valuable to your practice, please take a moment to rate and share the show. We'll be back next time with another exploration into orthopedic excellence. Thank you for joining us.